Hi everybody, welcome back to those who are just joining us. We are speaking with Dr. Venkat this afternoon, who is the medical director and founder of Harley Fertility Clinic, based in the most beautiful clinic location in central London in Marylebone. And today we're going to be talking about baby loss and treatment options following loss, which I know is an incredibly sensitive topic. And during Fertility Week and also Baby Loss Awareness Week and Month, we did, of course, discuss it a lot, but today we're going to be talking about treatment options. So Dr. Venkat will be speaking about testing that's available, why loss can occur, how you can potentially prevent it through treatment. All sorts of questions that you have sent in will be answered today. So thank you for your patience. She should be here any second. One of her consultations ran over, but I have been assured she's coming now. So please have your questions at the ready. I know that it can be an incredibly sensitive and triggering time, especially around the holiday season. So this is why we're having this conversation today, to help people make some informed decisions, learn more, be educated, and have your hand held, if you like, as we're approaching Christmas. So please bear with us, and she should be here any second. Hi to those who are joining. Nice to see you today. Let me see if I can invite her in. Hello, everybody. Nice to see you. If you have any specific questions that you would like to ask Dr. Venkat, please feel free to drop them in the comments box. If you don't feel comfortable doing that, that's no problem. Please feel free to DM us or DM Harley Street Fertility Clinic, who would be very happy to help you. Let's see if she's here. Thank you so much to the person who has also just sent us a message with questions. As soon as Dr. Venkat's here, I'll make sure that we ask those. So yeah, do feel free to send a private question if you like as well. Hi to those who are joining, nice to see you today. Just give it a couple of minutes, and if not, we will reconnect. I can see she's trying to join. Hopefully she'll be here in a second. Lovely technical glitch on a Wednesday. Hello everyone, nice to see you. I'd love to know, where are people joining from? Tell me if you haven't already. On Harley Street Fertility Clinic. Oh, they're joined. Okay, great. Are based in a beautiful clinic in central London. Hello, Dr. Venkat.
Hi, Elias.
How are you?
I'm very sorry about the delay in joining you. That is because I was.
Dr. Venkat, we can't hear you. We can't hear you. Can everybody hear me? Please, could you let me know if you can hear me?
Can you hear me now?
Yes, that's better. And if you could pull your camera down a little bit so we can see your face, that would be wonderful.
Okay, I'm adjusting now.
A little bit further down would be great.
Can you hear me?
Yes. So
okay,
please, could you introduce yourself? I've just given the clinic a lovely introduction, and we've done many lives together before. So thank you for your time today talking about fertility treatment following loss. Please do introduce yourself.
Thank you, Elias. I am Dr. Venkat. I'm the director of Harley Street Clinic. My sincere apologies for joining late, as I was held up with the patient. I always must take the time necessary to be with the patient and
Absolutely.
held up. And this fertility after a loss, because that is an important. Not many people talk about it, and it is even difficult for
I'm
the
sorry,
patient.
Dr. Venkat, we can't hear you very well.
You hear me now?
It's very, very muffled. It sounds a bit like you're underwater, I'm afraid. If everyone could let us know how you can hear.
Can you hear me now?
That is better. That is better.
Okay, I will hold my phone nearby.
Okay.
So that sound should be better now. And because I know last time the
This is
sound was not.
perfect. This is perfect. Great. So we're talking about baby loss. I know it's a subject that can be very sensitive and triggering. We talked about it in October during Baby Loss Awareness Week. And we're talking about it today, which I think is incredibly important in the lead up to the festive season, which can be very triggering for people. May I ask you, do you see a lot of patients at Harley Street Fertility Clinic who have suffered loss or recurrent miscarriage?
Yes, Eloise, we do see a lot of patients, and not only a lot of patients, we see patients who have had 5 miscarriages, 8 miscarriages, 10 miscarriages, and it is heartbreaking to see them because when they come and see me, they are in such a state of mind. They find it too emotional to talk about all these losses. And when they go and see any doctor, they do some investigations and ask them to go and try again to another miscarriage. They tell me nobody takes it seriously, which is not very helpful for such couples. And we see a lot of them and we investigate them, and we have had successful results with such couples after appropriate investigations and treatment. I'm happy to say that, so that this will give encouragement to those couples who are in such a situation, Eloise.
That's really good to hear that you're able to offer that support. Please, could you tell us a little bit more about why loss can happen and if there are any preventative measures or testing options that people can have to support carrying a pregnancy to term?
Okay, so, there are different stages we have to look at, Eloise, to find out why this is happening. And we usually talk about pregnancy losses at different stages of pregnancy. The first one we talk about, which is most common, is the early pregnancy loss. That's what we are referring to today. The miscarriages in the first trimester of pregnancy, which is less than 12 weeks. And the common ones are between something like 5 to 8 weeks, the commonest time when they miscarry. It can be due to some chromosomal abnormality. Yes, all the first trimester miscarriages usually, due to, or most of them are due to chromosomal anomaly in the embryo or in the fetus, we can say. This chromosomal abnormality leads to the miscarriage. Therefore, nowadays in our clinic, what we do is when we do IVF, we advise couples to test their embryos. And if we test the embryo and transfer only the chromosomally normal embryo, which we call euploid embryo, it leads to a pregnancy and healthy baby, not a miscarriage. So it reduces the risk of miscarriage immensely. So we advise them, look, if you don't want to have the pain of a miscarriage, it's better to test the embryo and have the embryo transfer after that. But for natural conception, of course, it's a different matter. We do all the tests and then advise them. So if there is an embryo issue, then we tell them, look, natural conception is not going to be helpful under these circumstances. You have to have IVF and test the embryo. But in some cases, we do other tests to find out if there is any other problem. Not only the embryo, it's also the implantation issue, which can cause problem. So, for example, if there is a structural abnormality in the uterus, like septum or biconvate uterus, these things, because the embryo implants in one half of the uterus, which is smaller than the other, or on the septum, which has a lower blood supply, they end up having a miscarriage, right? And because of this, we say if there is a structural abnormalities, they need some treatment. Some patients need resection of the uterine septum to clear the abnormality in the uterus. So uterine environment should be perfect. And if you rule out all those, then the next factor, which is very important, is the immune issues. There are some immune factors in the body, which is more common in women over the age of 35 and 40, or those who are going for egg donation. In those cases, there are some immune issues. They could have some clotting disorders or autoimmune antibodies. That means they have antibodies in their system, which is on overdrive, which kills the own tissues. That is called autoantibodies. And these can go and attack the embryos and cause problems. And thirdly, there are certain things called natural killer cells and cytokines, which are chemicals, can affect the implantation of the embryo with the continuation of pregnancy, leading to a miscarriage. That's why it's important to check all these things and to find if somebody's immune system is having high inflammatory markers. Okay, and if these are corrected before one gets pregnant or during pregnancy, during treatment, then we can definitely reduce the risk of miscarriage very much, and the person is likely to end up with a healthy baby. And we have successfully treated women with 8 miscarriages and 10 miscarriages by doing it. But all of them naturally, as soon as you're pregnant, come and see me. Then we confirm the pregnancy by the hormone levels, and then we do the immune treatments.
Okay, great.
Now,
we lost you for a minute, but I think we have you back.
Okay, is it clear now?
That's better. Yes, it's fascinating what you're saying. I have a question for you, please. You mentioned PGTA reducing the risk of miscarriage. Do you recommend PGTA for all of your IVF patients?
Yes, there is another reason for that. That is a very good question, Eloise, because you say if you take a population where they have had recurrent miscarriages, then we can reduce the risk of miscarriage. Okay, but at the same time, we have patients going through IVF. Then why do they need to test the embryos, you might ask? That is because they might have the miscarriage first time if we transfer the chromosomally abnormal embryos, or sometimes they may not get pregnant at all, in which cases it's better to test the embryo. For example, if someone has got 6 blastocysts and they are going to freeze them and use them later, we say test these embryos, because all the 6 embryos are not going to be chromosomally normal. Even in a 35-year-old woman, 40% of the blastocysts are chromosomally abnormal. Only 60% are chromosomally normal. That means if you have 6, 1 or 2 is likely to be abnormal. Which ones do we transfer? So the important thing is to transfer the right embryo into the uterus to get a healthy baby at the end. And that's why we say you want to reduce the time to having a healthy baby, or in other words, what I am saying is, if you want to get pregnant in the first attempt with a healthy baby, do PGTA and transfer the right embryo. That's very important.
You mentioned that you do immunology testing as well. Please, could you tell us a little bit about what you're looking for with that, and how treatment for immunology can sort of decrease the risk of miscarriage and who it might be suited for?
Yes, because their immune factors are on an overdrive. How we find out is they tell me, doctor, everybody gets cough and cold. I never get flu in the winter. That's because her immune system is overprotecting her from all these infections. And that's why her immune system is on overdrive. Like I mentioned before, it may be the natural killer cells or cytokines which can cause problems, or it could be antibodies affecting the embryos, the antibodies, if they are at a higher level, they're like thyroid antibodies, anti-nuclear antibodies, they go and attack the embryos, prevent implantation or cause miscarriage. Similarly, sticky blood, we call it in layperson's terms, or thrombophilia, these things have an increased risk of blood clotting in the placenta, which reduces the blood supply to the fetus, and that can also cause miscarriage. What do we do under these circumstances? We give them blood thinning injection, like injection Clexane, that's called mini heparin. Doesn't have to be given intravenously like heparin injection. This is given subcutaneously daily. And we can also advise them to take aspirin tablets to reduce the blood, sticky blood effect. So these two, blood thinning injections as well as aspirin tablets, are useful. And if someone has high level of autoantibodies, Eloise, the important treatment will be steroid tablets like dexamethasone or prednisolone, which will reduce the level of the antibodies in the system. And in addition to that, we give what are called intralipid infusions to bring the antibody levels down. Similarly, if the natural killer cell levels are high, or if their ratio is also high, how do we bring the levels down? That is also by giving the intralipid infusions. But there are certain chemicals which are secreted by these natural killer cells. Basically, natural killer cells means they are not different. They are simply the white cells in our body. And these have the defense mechanism. That is, they are supposed to protect the body from infections, bacterial and viral infections. So whenever they get a foreign body, like bacteria, they go and attack it. So when the embryo reaches the uterine cavity, they think that this embryo is a foreign body, we should go and kill the embryo, attack the embryo. That's their thought. So these natural killer cells secrete some toxins. These are called cytokines, Th1, Th2 cytokines. It's like a chemical warfare. Imagine that. So these are chemicals. If they are at a higher level in the uterine cavity, they can also destroy the embryos and prevent implantation. Or somehow, if the embryo is strong and implantation takes place, they prevent the pregnancy by reducing the blood supply and other factors. That's why these are not very helpful. And how do we treat these conditions? These cytokines are reduced by what is called intravenous immunoglobulin. You might have heard of it, Eloise. It's called IVIG. A lot of patients would have heard of it. And they are really very effective in controlling these cytokines. And of course, there is a lot of controversy about this intralipids and IVIG. Our regulator, Human Fertilization Embryology Authority, they don't support this because it's not evidence-based. I must tell you, it's not evidence-based. However, in my life, I have made so many babies in patients or couples who have had multiple miscarriages, like 8 or 10 miscarriages, and we have made babies for them in the first attempt of IVF. All of them have gone home saying, this is a miracle baby after
And
8
that's
miscarriages.
immunology treatment.
Yes, it is all immune treatments. So therefore, I believe these babies will not be on this earth unless we had this immune treatment. That's why I tell them, look, in selected cases, these have definite role, and we have to give it to the right patient, not everybody.
Yes, I had immunology treatment, and it uncovered me having factor V Leiden, which I know many of our readers have mentioned before, and I needed to do everything that you mentioned about the aspirin, the Clexane, the steroids, and also compression stockings. I had to wear
Yes.
compression stockings too, and throughout pregnancy, the whole way, and continue the Clexane injections all the way through pregnancy as well. So it's really interesting to discuss how that is so important, even during the early conception part of the journey as well. And how much of miscarriage do you think is related to the embryo versus implantation and the uterus environment?
Okay, so we say that normally 15% of the pregnancies are miscarried in the first trimester, and out of the 15%, I would say if you take those miscarriages, something like 50% or 40 to 50% will be due to chromosomal abnormalities. Okay, and the remaining cases are due to immune issues, and in 5% of the cases we have uterine structural abnormalities,
Yes.
like uterine septum, whereas the commonest is chromosomal abnormality. The next commonest is the immune factors.
Do you look at giving your patients who may have experienced loss further or more progesterone after their transfer?
Oh, yes, that is a very good question. I say, if they ask me, there are so many hormones during treatment and in pregnancy. Doctor, which one is important? One hormone which is very important during IVF treatment, maintenance of pregnancy, and pregnancy, to prevent pregnancy loss, is progesterone. Progesterone. Because I know that some of the IVF patients don't get pregnant because their progesterone level starts going down. And that's why in some patients we check the progesterone levels at regular interval. And some pregnancies, it's not only IVF pregnancies, some natural pregnancies are also lost because of reducing progesterone levels. So I always ask such patients are advised to come and have regular progesterone check, and if needed, progesterone supplementation till 12 weeks of pregnancy. In IVF cases, routinely we give progesterone supplementation up to 12 days.
I was going to say, does it matter? Well, at Harley Street Fertility Clinic, what type of progesterone? How does the application happen? Is it through injections? Is it through pessaries?
Okay, that's actually, yes, that is another important discussion, because there is a lot of different beliefs in this, even in this country and across the countries. For example, we say first line of treatment is progesterone pessaries. That's the easiest and simplest. And if we check the progesterone level, and if it is maintained with that, we carry on with that. But for example, in frozen embryo transfer, the progesterone needed is very high. And therefore we prefer to give intramuscular injection of progesterone.
Okay.
That gives the highest concentration of progesterone. And there are research papers which say that if someone has got intramuscular progesterone, the chance of getting pregnant is high. Or you take two groups, one with intramuscular progesterone, one with vaginal progesterone, the pregnancy rates are definitely higher, much higher in the injectable progesterone groups. And in USA, routinely give intramuscular injection progesterone. And here now we are also giving it in our clinic for the frozen embryo transfers. And our success rate with frozen embryo transfers is 70%.
Wow. Amazing. We've had a great question. Why are GPs reluctant to try or prescribe progesterone?
Yes, I mean, that's a difficult question to answer, because in fact, we have had patients into our clinic saying that she has had 2 miscarriages and the GP refused to give the progesterone before she has 3 miscarriages.
Wow.
And also the GP say that there is no evidence that progesterone will prevent miscarriages. But that is true. It will not prevent miscarriages in all the cases. But there are cases where the progesterone is low and it is indicated definitely.
Mm-hmm.
Either they should check the progesterone during pregnancy and give, or give them. But lots of GPs, they don't believe in. And also, I say GPs are not like fertility specialists. They don't know the full ins and outs of the fertility. And obviously, we can't expect them to be specialists in all the fields. So it is difficult for them.
Absolutely.
Recently, there's a lot of lack of resources in the NHS, though they are trying to keep the budget tight. There are so many reasons, and we know that that is happening. And some patients have come to our clinic asking for progesterone prescription, which of course we see them and do the progesterone test and give them if it is needed.
Good to know, thank you. And if you do want to get in touch with Dr. Venkat and the fantastic, very family-orientated team at Harley Street Fertility Clinic based in central London, please do head to our link in bio to find out details. You can also DM us through Instagram or them, and they'd be very happy to help you with a personalised plan and next steps, especially around this topic of loss, which I know is something that you see patients about all the time and have a lot of experience in. I wanted to just quickly ask you about emotional support. We've talked about treatment from a medical point of view, but for people who are struggling with loss and sort of going back into treatment or starting treatment, how does Harley Street Fertility Clinic support people holistically with psychological care?
Yes, that's a very important point you raised, I would say, because psychological support is very important for such couples. Not only the woman, the man also grieves the loss and they don't express their emotions, as you know. And it's important for them to have a good counseling session with our counselor. We have fertility counselors in our clinic. We have one in-house, and sometimes we refer them outside also to the miscarriage counselors. It is always helpful. We also have other support like Harper's support. These are fertility coaches, and they will make regular phone calls to people who are going through miscarriage or just after miscarriage to make sure that they support. And on top of all this, the basic support we offer is our nurses. They hold the patient's hands during the difficult time of miscarriage, because when they are having the beta HCG and progesterone at regular intervals to check how the pregnancy is going, and we know that at some stage they are losing the pregnancy, the patients are aware of it. That is a very difficult time for anybody. And our nurses talk to them face to face, sit and talk to them after every blood test, and also they speak to the counselor. So I think they have multiple support in our clinic, because that is very important. We attach a lot of importance to the counseling with this.
Hugely important. And for anyone who is seeking a second opinion, a first opinion, wants to find out more, get tested, whatever that might be, please do head to our link in bio to speak to Dr. Venkat and their wonderful team for holistic care, medical side, but also with, as you mentioned, counselling, acupuncture, nutrition, all kinds of holistic support. So thank you very much for your time today, Dr. Venkat. We really appreciate it. And I know that you were seeing patients earlier, and it was a pleasure to speak to you today. Anything you want to end with on this topic?
Thank you very much for this, Lois, because there are a lot of couples having repeated miscarriages, and it's good to have support here. And I would like to tell them, look, there is light at the end of the tunnel. There is hope for you. Come and see us. With the right treatment, you will definitely go home with a healthy baby in your hands. That is the important thing. Don't give up. There is hope for you.
I love the positivity. Thank you for all of that. And please do reach out to us or the team for further support. Thank you very much, Dr. Venkat. And thank you for those who have joined today. Speak to you soon. Bye-bye. Bye.
Bye.